specifically multi-omics data. So this session is entitled CBT at the Forefront, Leading the Multi-Omic Multimodal Data Revolution. I think in pondering the various talks that we've assembled here, I think actually multimodal data in support of clinical decision-making would have been an alternative title that may capture kind of the aggregate of the speakers in this next session. I do want to point out that in a peak of poor planning, we've made an educational session that is concurrent with this, which is entitled Bioinformatic Analysis of Multimodal Data. So probably the same audience would be interested in both of these, but not trying to drive folks away. But if you are interested in the educational session, it is a 2:00 session, which is now. So think about that. So our first speaker is Todd Holland from the University of Michigan. Hope I pronounced your name properly, Todd. He's been doing some really, really interesting Raman spectroscopy intraoperative data acquisition work that's really transformative in a sense that it's providing a very unique data set in a very critical time period, which is at diagnosis in the operating room. And when it comes to sort of trying to discern tumor from normal, it's always been something I've marveled at, the neurosurgeon's ability in the operative field to know when to stop. We review post-op scans, and it's remarkable what they're able to achieve and the accuracy with which they discern that without tools like the ones Todd's developing. And so I can only imagine how much better it's going to be. But please join me in welcoming him.
Thank you all very much for the opportunity to be here. This is really an impressive conference. A big thank you to Carl over here, Koshman. He's an excellent colleague, gave me the invitation. So my lab really focuses on how do we do better surgery and incorporating some of the latest tools from artificial intelligence. It's a big week for us, by the way. 2 Nobel Prizes went to AI investigators. So really happy to see the momentum building. So, this is again focused on how do we really help surgeons do better surgery. And it's still amazing to me that it's an open question. We're in there operating, we're removing these tumors. It's true for adults and pediatric patients where it's very hard, even in the 21st century, to determine what is normal brain and what is tumor infiltrated. And it seems like that should be a solved problem, but it really isn't. And everybody hear me? I better. And my job, I think, as a data scientist, computer vision researcher, and as a surgeon is try to solve that. I feel like by the end of my career, we should have this problem solved for any tumor. And the normal way that we analyze tissue in the operating room is something like this. We have a surgical specimen. This can be in the patient or it can be something that we've sampled. We send it to a pathology lab. It's usually called a frozen section lab that may be adjacent to the operating rooms. It may be in a different building. But we do some testing, and this can be, again, intraoperative or potentially after the operating room where we do it, where we do other molecular testing like immunohistochemistry or sequencing. We then rely on a neuropathologist to integrate all of that information and give us back a final diagnosis. Now, in the intraoperative setting, it's a weak approximation of what the final diagnosis is. That's the WHO diagnosis that would inform treatment decisions down the road. But we as surgeons, we get some kind of hedgy diagnosis. And the reason is because the images just aren't that good. It's very hard to tell whether this is an ATRT or a medulloblastoma during the surgery, right? And that's where we're stuck. As a surgeon, you're in there, you're trying to do the best operation that you can, and they tell you, well, it looks a little embryonal. That's about as much as you'll get, right? It's not the pathologist, it's just that it's a really hard diagnosis to make. So what we have been developing is a parallel pipeline where we're imaging the specimen in the operating room. It does not leave the operating room, stays in the operating room with this technology called stimulated Raman scattering microscopy. We get these amazingly good high-resolution images that do not require any staining at all. So you don't have to stain it with H&E or immunohistochemistry. You're just getting a digital image, and then my lab has been focused on building out the AI and computer vision methods to help interpret these images. And the hope is to have a prediction that is at WHO grade diagnosis. So it's not just going to tell you this is a spindle cell neoplasm. It may tell you that this is in fact a meningioma. It's a WHO grade 3. And in fact, this does have a TERT promoter mutation, all from the images themselves. And this takes, about a minute to go from tissue out of the patient to ultimately a diagnosis. And we've been trying to attack this in a kind of layered approach. So that way we're getting the most out of every tissue specimen and the most information back to the surgeons. And also to the families, it's really important for the family to know, and they always ask me after the surgery, what do you think the tumor is? What do you think that this was? And oftentimes I say, I don't really know. We're going to have to wait 7 to 10 days. All of that time you're waiting, do we enroll them in clinical trials? Do we give you any early adjuvant therapy? Do we give you any intraoperative treatments? All of those things are bottlenecked because we don't have that diagnosis. So histologic classification, tumor recurrence. I do a lot of skull-based tumors. That's important. Molecular classification is increasing in its importance across pediatric and adult patients. And then finally, tumor infiltration detection. That gets to the point where it's still hard for us to determine what is tumor and what is normal brain. So these are the images. I just wanted to show this briefly. So this is an optical imaging method. Basically just shine laser. Usually it's one laser for Raman spectroscopy. In this case, you're using 2 lasers that give you this nonlinear amplification of the image. And you get these grayscale images. I love these because these are digital images, because that means we can do something with them in the OR. If it's a slide that you're looking at, frozen section, that's analog data. We can't really do much with that. Slide scanning really hasn't caught up yet to be able to scan those images fast enough to be able to do something with them during the surgery. And then we can color these grayscale images however we want. So for example, this down here, this is not an H&E image. We've developed a color scheme to actually make it look like an H&E image, when in actuality, this is these digital images that we get in the OR that have just been colored, so that way they look like all the histology we've learned when we were in med school. So we decided, how do we use, at the time, state-of-the-art computer vision methods to be able to diagnose these and give us histologic classification. So this way this works, patient comes in, has a suspected brain tumor. We do the surgery, we sample this, we put it in the microscope. These are commercially available. I don't make any money from these. I am not conflicted here. So again, you can buy these. Several institutions, I think we're up to 20 across the US and Europe, are now imaging these. You can just have your hospital buy them. So, and then again, the latter half is now the stuff that I work on, where we have to process the images. We cut them up into smaller patches. And then at the time that this was published, we were using the state-of-the-art neural network architecture, which takes in the patches. You do a little bit of averaging, but the point is the output is a probability distribution over the 13 most common brain tumor types. So we just selected, we needed at least 10 images in order to be able to validate this, and given a specimen, we'll be able to give you a diagnosis out. Now that's the easy part. The hard part is testing it. This is what I always say is, if you have an Excel spreadsheet, you can do an AI project, right? You have to test it to prove that it actually works. And this is where we actually set this up as a clinical trial. So we said we're going to have our AI arm, that's the experimental arm, as well as the control arm, which is the pathologist interpreting frozen section images. And we wanted to treat it in a head-to-head comparison study to see how well we did. Now, in real life, the pathologist can have both, right? They're going to be interpreting the frozen section in the context of our prediction, but we wanted to be able to show that that information that they got out of the AI would in fact be helpful for them in making the diagnosis. And these are the results. So the left-hand side is the conventional H&E, those are the pathologists, and then the right-hand side is the SRH with the convolutional neural network diagnosis, and we were able to show that we were equivalent in terms of overall accuracy, which was our primary endpoint. What you can actually glean from these confusion matrices is there was no overlap in the errors. So in the instance where the pathologist got it wrong, the AI got it right. And when the AI got it wrong, the pathologist got it right, which just demonstrates to you the synergy of the fact that we can really use both of these modalities to improve the way we evaluate tissue in the operating room. Now, that's great. Histologic diagnosis is still around. It's still important. But ultimately, the field is really moving towards molecular classification, whether that's in the form of somatic mutations or methylation testing. And in gliomas, diffuse gliomas in adults, we've really now gone, full on in terms of classifying these tumors based on the molecular genetics. It's one of the earlier tumor types that has really now defined these groups based on their molecular genetics. Why is it important for surgeons? We know now that the surgical endpoints are different depending on what tumor you have. You should be more aggressive in terms of removing more tumor in some of the molecular subgroups. Now, the problem is that we don't know what molecular subgroup you're in as the surgeon at the time of the surgery. So this is non-actionable information. When you see these Kaplan-Meier curves, there's no way for us to act on this unless we have the molecular diagnosis during the surgery. So that was what we really sought out to address. So similar setup here. We get our image on the left. Again, not H&E. This is our image. We've just colored it to look like H&E. We focused on the three most common mutations that we see in gliomas: IDH, 1P19Q, and ATRX. We used some better technology in order to be able to predict these diagnoses. But we get out these heat maps in the operating room, and then you can integrate all of these predictions into a single heat map for each one of the molecular subgroups for, in this case, diffuse gliomas. I will say we're now working on both DIPG as well as medulloblastoma. So this is general technology. You can kind of plug and play what tumor you're most interested in. And then again, testing. We ramped up our testing. We wanted it to be multi-center and international. So we recruited 4 other sites: UCSF, NYU, Cologne, and Vienna as testing sites, all external testing prospective. And these are the results. So our primary endpoint was a balanced accuracy of greater than 90%. This is tough. This is prospective data, so you can't control for this. It's just the patients that get in, and then ultimately you do the analysis once, and there's your paper, right? So luckily we were able to meet the endpoint for the different mutations that we were interested in, and this was a big success. Again, these are classifications that pathologists won't be able to give you, just because there's no reason to believe that you'll be able to, as a pathologist, learn all of the different morphologic features that you may see in these images to be able to detect whether there is an IDH mutation or an ATRX loss. So this is another slide that I like to show, because if you're testing, let's say with immunohistochemistry, the type of mutation, the type of point mutation is going to determine whether your IHC is positive. So, for example, the most common screening test that we have is R132H immunohistochemistry for diffuse gliomas. Those are, again, both adult and pediatric tumors. The problem is that you can have other IDH mutations. So you're actually going to have a false negative in the instance where the patient does not have that specific point mutation. So much so that they've mandated now that certain patients need to undergo sequencing when you have a negative IDH screen. We've built this to be invariant to that. So you can have different point mutations for different specific mutations across different tumor types that can still predict positive. This is an example of an IDH2 mutant oligodendroglioma. The laboratory screening that you would use would be negative, but here it's positive because the AI can predict it regardless. So this is, again, an instance where digital pathology can sometimes outperform conventional laboratory medicine, laboratory pathology. And then extent of resection and tumors, right? This is something I feel very strongly about. Historically, all the research that has gone into the importance of extent of resection and the patient outcomes has been measured by postoperative MRIs. So we measure how much residual enhancement or flare signal change is on the postoperative MRIs. This has been completely indoctrinated into us. It is the status quo. The problem is that we know MRIs are bad measures of residual tumor burden in any infiltrative tumor. So the metric we use to even evaluate the clinical efficacy of these is wrong. It's a noisy metric, right? So the issue, we do not have an ability to evaluate microscopic residual disease that potentially is MRI occult. We just can't see it on the MRI, right? So what we have been trying to figure out is how can we assess microscopic tumor burden that would in fact not be present on an MRI. Okay, so you've kind of seen a similar plot like before. In this case, this was another study that we conducted where rather than sampling in the core of the tumor, we're sampling around the periphery of the resection cavity. And this was across multiple different glioma types. But the point is we're now focusing on the tumor margin, and we're trying to quantify how much tumor infiltration is at the margin of a resection cavity. And again, we're acquiring these images. We had a certain sampling protocol, et cetera, et cetera. But we started out with a visual foundation model, which I won't go too far in, but you guys have all heard of GPT now. So GPT is the foundation model. ChatGPT is the fine-tuned version of this for question and answer tasks, right? So we trained a visual foundation model specifically for the imaging data set that we have. This is the simulated Raman histology. But then we fine-tuned it to actually score to give a scalar value between 0 and 1, 0 being normal brain, 1 being dense tumor infiltration. So the number that you get out of that should tell you how much tumor burden is in that specific specimen. And then we get these nice, cute little heat maps in the operating room to localize the areas of tumor. So, okay, so foundation model training, it's a big deal. Everybody talks about foundation models. That's DALL-E 3, ChatGPT, all these different models that are currently available. But the thing is the underlying technology with GPT is just next word prediction, right? You don't have to supervise anything. All it is you take the entirety of the human corpus of written literature, written text, and you just predict the next word. The advantage of that is you can just use it, all of it. You don't need any annotators. You don't need anything to sort of external supervisory signal to train those models. Same thing is true as an image. So if I can take an image, what I'm going to do is I'm going to select a specific crop. So I select this crop, I mask certain regions, and then I pick another crop, I mask certain regions. And the point is that you're going to train this such that the model needs to learn that these are from the same image. These two crops are representative of the same tissue. That's equivalent to kind of next word prediction, where given this section of the image, I'm going to predict now this other section of the image. And you can do that with, in this case, we had over 11,000 whole slide images from 4,000 patients. Now, again, what you get out of that is a base model that then we can fine tune in order to do tumor infiltration detection, which is what we did. So this was 4 different medical centers, and we were able to show, if you look at the ROC curves for predicting different degrees of tumor infiltration, we were able to do very well, greater than 90% accuracy. And actually, the lines that you see on the plot on the right-hand side, this is every single specimen that we had in the whole cohort, and we had basically a decision boundary at 50%, where it would be likely normal versus likely tumor. And again, we had to do a ton of extensive analysis to prove that in fact there was higher degrees of tumor infiltration in the higher scores. So this all looks great. These are some of the examples from the different institutions across the U.S. and Europe where we were able to quantify these degrees of tumor infiltration. And then again, if you look at some of the internals of this model, the model had clearly learned that there's a distribution of tumor infiltration across these different specimens, and we were able to show that. Each dot here is a whole slide image that we were able to plot here along a single axis which quantifies the tumor infiltration. Okay. Now, one thing I was really excited about that, if you're going to claim something like foundation modeling, which the goal here is to just generalize this to any tumor type, not only also pediatric brain tumors, but prostate specimens, thyroid, breast, lung. I wanted this to be a technology that's general. If you're going to claim that, you need to show that this can generalize to instances that you did not train on. And that's what they often talk about, zero-shot learning. You may have heard that. But the point is that we didn't train this really on any diffuse midline gliomas or pilocytic astrocytomas, but you can always test. You can always just inference, put it in, right? So we were able to show that actually the scoring of the degree of tumor infiltration generalized to DMGs as well as pilocytic astrocytomas, which again was a big win for us. In terms of other tumors, like I mentioned, embryonal tumors, so medulloblastoma, we did really well. Same thing with CNS neuroblastoma. So last bit I'll mention is we wanted to test this against the state of the art, the current standard of care. We use intraoperative MRI and we use fluorescence guided surgery to detect tumor during surgery. So we wanted to do this one-to-one comparison. Point is we really outperformed the tools that neurosurgeons have available to improve surgical care for our brain tumor patients. And this included pediatric and adult patients. But the point is that, you see the ROC curves here. Up here, this is us, this is the performance, but this is the fluorescence guided surgery, and then is flare positivity and contrast enhancement for intraoperative MRI. The important part about this is that we don't want to leave tumor that's safely resectable in our patients' resection cavities, because that's what we now need to target with radiation or chemotherapy. If we're using the technology I'm describing, only 3.8% of patients in our prospective test actually had residual tumor in the specimens that we were sampling, versus something like a quarter of all patients had safe tumor that we should have removed at the time of surgery residual, right? We basically got to get this down to zero. There's no reason we should leave safe tumor in anybody's head any longer, right? So we're working on it. So great. So this is my lab. I run the machine learning and neurosurgery lab, and it's just really exciting to see the, just the enthusiasm for data science here and AI. So thank you.
Thank you, Todd. That was amazing. Any questions for Todd? I think we have time for one, perhaps. Carl has a question. Like, you never have an opportunity to talk to this guy? Go ahead.
world. And is obviously the idea would be that the Children's Hospital would have to have one of these Raman spectroscopies. And then would you implement it in a prospective way where it would be on clinical trial, off trial, disease specific? Just give us some sort of high level ideas.
Yeah, so I think a lot of the diagnostic techniques that I've talked about here, I think that's immediately translatable to the pediatric population. The imager itself is FDA approved, so there's no other sort of regulatory stuff that needs to happen. In terms of deployment of the kind of AI on these systems, that's where it often is a situation where I'm happy to give anybody these models. I believe in open source technology for this. I think that it's going to be critical to get these things clinically translated. Working together as a research consortia, I think is the best short-term solution. Long-term solution, I think the FDA is still really struggling to know how to approve AIs that are level 3 devices, basically where it's going to determine an intervention, right? I think it will happen, but I hate to kind of let our patients wait for that in a way. Ultimately, the surgeon it's up to them to decide how they use this information. It's similar to an operative microscope where we're actually operating under magnification. The AIs that you can have as investigational tools on here can be used freely by the surgeons as they see fit. That's currently being done. We've had that approved by IRBs. So, I think we sort of have to let the FDA and really the future sort out how these interventional tools get deployed. But I think it's an open question for the community how they want these AIs to influence patient care. So, yeah.
Yeah. Do you think there are ways that it will transfer this approach maybe into fresh frozen even, or can you take the Raman data, right, compared to fresh frozen and sort of augment the fresh frozen analytic framework in this way?
Yeah, absolutely. Because frozen section is ubiquitous. And I think that we have looked into doing similar kinds of predictions from frozen sections. So, for example, just predicting certain mutation status from frozen. The results are better than one might think. One of the challenges is the heterogeneity of the data, because if you go to CHOP or University of Michigan, the staining is very different, and that, despite these models being very good, they're very brittle. So if it's just a little too red, sometimes it won't work very well. But the point is that I do think all computational pathology systems, whether it's permanent or frozen, they should have some predictive analytics to go along with them. So.
That's really great work. We've talked about this before. Mm-hmm. We have been trying to get one of these systems for University of Zurich, but the company is making one system per month.
Yeah.
And currently they're behind.
Yes.
On the research side, if you would just have a benchtop Raman spectrometer, would that do the trick for us to train our models based on the system that we have? On the research base, could we actually just use a cheap benchtop Raman spectrometer to do it?
Yeah. It's a little challenging. So for Raman spectroscopy, you're actually getting a broadband spectra out from that, and you can buy those again. But for this technology where you're actually getting a narrow band image out of it, right? We're just picking a certain point in that spectra. You'll get an actually image that we can predict from. So it's a little bit different technology, the stimulated Raman versus the kind of point Raman spectroscopy. Now, having said that, though, there are some papers out there that have looked at actual Raman spectroscopy to predict these certain things, and the results, again, are quite good. You get rich biochemical information, you just don't get the spatial information where you get a big image. So my hope is the company gets their stuff together and they start producing these at a higher rate, because I think that we have the tools to deploy this and people seem to really take to this technology. I certainly want everybody to have one of these. I think it should be a new standard.
So just out of curiosity, you said you could actually use this like almost real time in the operating room.
Yes.
So what's the learning curve, so to speak, for actually being able to use it? Are you going to need somebody like an expert in this this technology to be there, or is it kind of user friendly enough that it can be done by just whoever happens to be in there?
Right. Extremely user friendly. So there's no preparation of the tissue. This is what people still blows their minds. They think they need to be a microscopist. The tissue is fresh tissue and it goes into a pre-made slide. You just close the cover slip and you put it into the microscope. So there's no preparation that you need from that. One thing that surgeons often worry about is the interpretation of the image, because you're going to get an image in the operating room. I liken it to the fact that as clinicians, we read all of our own MRIs. Every MRI we get, we read for our patients, right? We feel completely comfortable with that. I'd say it takes, a couple of weeks to a month to be able to clearly differentiate between, let's say it's a metastatic tumor and a glioma, or a pilocytic and a diffuse glioma. So I think that these are all skills that we all have. We just don't exercise them that often. But I liken it to the way that we just unapologetically won't even read the radiology report, right? Because we read them. Yeah. I will say our pathologists have adopted to this. No, our pathologists absolutely adore it. I found that pathologists treat frozen sectioning a bit like call. They're like, oh, I have to go to the frozen section lab. I have to go read this ugly specimen. I don't want to speak for you.
We have a schedule here, Adam. No, Ian, by all means.
This seems like a great technological adjunct, just like intraoperative MRI and all the other things that you mentioned, 5-ALA and such. The difficult part is the safely resectable determination. We may see tumor in adjacent brain, which could be eloquent brain. And for example, if it's a medulloblastoma, you may see tumor in the brainstem. You don't want to take that out. If it's an ependymoma, you may want to do that level of risk. And does the machine provide that level of guidance on the histology at that moment that you can rely on the machine? And if the machine is wrong, who is responsible for that?
Right. Yeah. Right now, I think in terms of, functional cortex or eloquent regions, I think we really need to leave it up to the experts. We need to leave it up to neurosurgeons to dictate when it is safe and when it isn't. And that's why I think there is a clear demarcation between sort of safely resectable, and maybe it's not so clear, but there is a difference between whether it is safely resectable and not. And I think that we can't be hurting patients just because this says that there's more tumor in there, right? Eventually, we know that if we're causing neurologic disability, that the survival benefit doesn't translate. So I think that it's not just going to come down to imaging; it's also going to be functional mapping and other tools that help us know how best to remove these tumors. So.